You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for March 14th, 2025. This week, I'll do some listener feedback, resistant hypertension, potassium binders for MRA use in heart failure, nutritional epidemiology, and a positive study for vitamin D. First up, some listener feedback. Last week, I strongly criticized the CAUT-CAD trial, mostly on methodologic grounds. The trial tested the use of CAC scoring, coronary artery calcium scoring, to reduce plaque volume in intermediate risk patients with a family history of coronary disease. The trial was positive, but its trial procedures precluded making any reliable clinical judgments. At least that was my argument. This week, a Medscape journalist is working on a news piece for the CAUT-CAD trial, and he reached out to me for comment regarding a comments the senior author made about my appraisal last week. Quote, "I'm fascinated by the internet phenomenon of opinion propagation. There's no need to propose a solution to a problem just to denigrate any approaches other than the status quo. Nothing will ever change his mind because an outcomes trial with a required 20-year time horizon will never be done." Now, I'm not sure that this comment from the senior author about my comments will make it into the news article, but I include it because it is a comment I have heard from academic researchers before. In fact, the former FDA director, Dr. Robert Califf, once demeaned non-academic opinion writers on the internet as the peanut gallery, citing the Teddy Roosevelt quote, "the man in the arena." Basically, Califf argued, "Shut up if you don't do research." Well, my response to this is to say that being a researcher or doing research is not a criteria for doing critical appraisal. In fact, critical appraisal is most important for the users of the evidence, the doctors, the clinicians. Now, that sentence is all that I wrote back to the journalist, but let me add just a few more comments about this issue. On the matter of the, quote, internet and opinion propagation, I regret to inform this senior researcher and other senior researchers that the digital revolution, wherein ideas rise to prominence based on their merit rather than their source, like Harvard or Yale or ACC or AHA, is more than a decade old. Gone are the days where letters to the editors or lofty discussions from key opinion leaders at medical meetings are how ideas get established. Newsflash, we now have the internet. And on this internet are blogs and podcasts, and lots of people with lots of ideas. Many of these people with ideas are not PhDs or researchers, but sometimes that is in fact the strength. Now, take late-breaking clinical trials at major meetings, for instance. The place to be is not in the audience listening to the congratulatory trial discussants, but online where a robust discussion happens. The nanosecond the trial is presented, there are people with ideas about the trial online. People like Bogdan Inaki, people like Sanjay Kaul. My second response to the comment, quote, "rather than proposing a solution and nothing will ever change my mind, or that an outcomes trial will never be done with CAC because of the long time horizon, I would remind everybody that large outcome studies for screening tests have been done. Axel Diedrichsen studied this in the Dankavas trial. Screening CT scans have been studied for lung cancer, colonoscopies in colon cancer, mammography for breast cancer, as well as aortic screening have also been submitted to an RCT. A coronary CT scan, whether for CAC or CT angiography, places a patient into the health system, and that, my friends, is not a small thing. So, it should be tested systematically with outcomes. It is not tested because proponents like their place now where marketing has made the test popular. But I would say that these tests can induce downstream procedures or create fear, and this should be considered potentially harmful as well as beneficial. And given the mountain of evidence against revascularization for stable patients, the CT scan should be randomized Patients get the CT scan, patients don't get the CT scan, make it random, then look at outcomes. There is a ton of waste coming out of places like the NIH, but this is one area where a study could be and should be funded. All right, next topic is a new hypertension drug for patients with resistant hypertension. And I'm not sure why all new drugs have to be difficult to pronounce. The drug's name is Lorundrostat. It's an aldosterone synthase inhibitor, which works by inhibiting CYP11B2, the enzyme responsible for aldosterone production. The company that makes the drug, Mineralys Therapeutics, announced this week in a press release positive results of the phase 3 RCT called the Advanced Hypertension Study. Patients were already taking 2 to 5 blood pressure meds, one of which had to be a thiazide-like diuretic. The trial noted a placebo-adjusted reduction of about 9 millimeters of mercury after 6 weeks. Patients whose doses were increased to 100 milligrams per day after 6 weeks had an absolute reduction of 15.7 and a placebo-adjusted reduction of 8.4 millimeters of mercury after 12 weeks. One headwind here was a relatively high rate of potassium levels greater than 6 of 5.3% and 7.4% in the 50 and 100 milligram doses. This phase 3 study and a phase 2 study called Launch Hypertension will be presented at the ACC meeting that's going to be held in a few weeks. Now, as I have said many times on this podcast, I do not love science by press release. We will have to see the details when the trial is published. But this could be an important development because hyperaldosteronism is present in almost 1 in 5 patients with resistant hypertension. And a drug that directly reduces aldosterone, its production might fill a nice niche. The trial was short in duration at 12 weeks, but if that amount of blood pressure is sustained, it is substantially more than, say, renal denervation. And of course, this drug is much less invasive than femoral artery stick and ablation in the renal arteries. So we shall see. Now, speaking of aldosterone, we need to talk about a trial of a potassium binding agent called the REALIZE-K trial. Jack has published an RCT of sodium zirconium cyclosilicate, which I will subsequently abbreviate SCZ. Now, this was for the management of hyperkalemia during spironolactone optimization in patients with heart failure. Now, you're all familiar with the background here. MRA drugs are hugely beneficial in HFrEF and probably beneficial in HFpEF. That is, if you do a careful analysis of the TopCat trial. Now, for the younger listeners, it is worth pulling up the RALS trial of spironolactone versus placebo in HFrEF. RALS shows one of the largest effect sizes in all of cardiology, and that is for a generic $4 per month drug, spironolactone. The problem, of course, is that MRA drugs are often not given out of fear of hyperkalemia. Potassium binding agents hold the promise of allowing more MRA use because binding to K may allow MRA use without getting hyperkalemia. However, the trials are not so clear. The DIAMOND trial of patiromer, published in the European Heart Journal in 2022, found very modest reductions in potassium levels, and 31 placebo patients stopped at MRA versus 20 patients in the patiromer arm. That was a difference of only 11 patients. So the $1,000 a month potassium binder, patiromer, surely has little effect on heart failure therapy. The question in the REALIZE-K trial is, would the SCZ, or sodium zirconium cyclosilicate, fare any better? SCZ is an orally administered inorganic crystal that has high affinity for potassium ion and exchanges potassium for hydrogen and sodium. Previous trials of SCZ have demonstrated that it is effective at rapidly lowering potassium and maintaining normal K levels during long-term in patients with hyperkalemia. Most of these studies did not enroll patients with left ventricular dysfunction and heart failure, however. Now, patients in REALIZE-K had HFrEF, they were on stable meds, and they had to have a high potassium or they had to be at risk for MRA-induced hyperkalemia. Then, patients meeting all eligibility criteria entered an open-label run-in period for 4 to 6 weeks for optimization of spironolactone dosing and normalization of the serum K with the use of SZC as needed. After normalization of the serum K, spironolactone was initiated or up-titrated to a target dose of 50 milligrams per day, with then further adjustment of SZC dosing 5 grams every other day or up to 15 grams once daily orally as needed to maintain K in a normal range. Then, after the run-in period, there was a double-blind, placebo-controlled, randomized withdrawal phase in which patients were randomly assigned either to continue treatment with the same dose of spironolactone and SZC orally or to continue treatment with spironolactone and a matching placebo orally for 6 months. The primary endpoint was called optimal treatment response, that is normokalemia on spironolactone without rescue therapy. There were 5 secondary endpoints tested hierarchically, each measuring potassium outcomes, and there was an exploratory outcome of a typical heart failure clinical outcome, CV death, or heart failure event. The results, there were only 200 patients randomized, so this was not a heart failure outcomes trial. But the results were positive for potassium endpoints. The odds were more than 4x that the SZC treated patients would have an optimal response of a normal K on spironolactone. SZC versus placebo also had positive results on the other secondary endpoints regarding potassium and spironolactone dosing. The KCCQ quality of life scores were similar, adverse events were similar. However, get this is tricky. The composite of cardiovascular death or worsening heart failure occurred in 11% of participants in the SZC group versus only 3% in the placebo group. And that, quote, log-ranked nominal p-value was 0.034, so a positive p-value. The authors concluded that SZC led to a large improvements in the percentage of patients with normal K levels on optimal spironolactone dosing, as well as a reduced incidence of high K and a reduced incidence of down titration or discontinuation of spironolactone. But they also write, although underpowered for clinical outcomes, more participants had heart failure events with SZC than placebo, which should be factored into the clinical decision. My comments are that this is very interesting. The authors included clinical outcomes Kaplan-Meier curve in the central illustration of the paper, and they featured it prominently in their conclusions, even though it was a difference of 11 versus 3 events. This makes me think, was the worsening event rates just noise or was it real? A nominal p-value was positive, but again, it's an exploratory endpoint with very low numbers of events. Now, before I say anything about this, I want to highlight the accompanying editorial from my friend Dr. Milton Packer, who is an extremely clear writer and thinker. His editorial, and I'll link to it, is, do potassium binders block both the benefits and the risks of mineralocorticoid receptor antagonist in heart failure? The 4 anti-aldosterone myths. Myth number 1, Packer writes, many patients with heart failure cannot receive MRAs because of potassium. Packer cites the RALS and Emphasis trials and notes that clinically meaningful hyperkalemia when MRAs are dosed appropriately, which is at 25 milligrams, is rare. The mean dose of spironolactone used in RALS, which I've already said had a huge effect size in mortality, was only 26 milligrams. That's because uptitration to 50 milligrams in the trial was uncommon and rarely done. Packer writes that more than 80% of patients with heart failure should tolerate highly effective, that is, lower doses of MRAs, but in practice only 15 to 30% are receiving the drugs. Myth number 2, enabling the use of MRAs with potassium binders can be expected to favorably impact morbidity and mortality in heart failure. That's a myth. Packer knows that trials of potassium-binding drugs, like for instance the Diamond trial of patiromer, tend to focus on patients taking excessive doses of MRA because hyperkalemia is so uncommon at 25 milligrams per day. In Diamond, Packer notes the difference in MRA discontinuation of the placebo versus patiromer group was only 11 patients, which would have had a minimal effect on heart failure events over 3 years. MRA myth number 3. Potassium binders do not inhibit the effect of MRAs to reduce morbidity and mortality in heart failure. Here, Packer cites the results I just highlighted in Realize K. That is, that the SZC group had tripling of heart failure events versus placebo. Why did this occur despite enhancing MRA use? Because, Packer writes, the SCZ adds 800 milligrams of sodium, thus imposing a huge dietary salt load, which could clearly increase heart failure events. Myth number 4. Innovations in anti-aldosterone pharmacology will improve the benefit to risk profile of MRAs and heart failure. Now, relevant to my first story on the new molecule for hypertension, Lorundrostat, the aldosterone synthase inhibitor, Packer notes that these drugs are being developed based on the belief that aldosterone can exert adverse effects through mechanisms other than the mineralocorticoid receptor. Now, the problem with this, Packer writes, is that MRAs antagonize numerous genomic and non-genomic pathways that may contribute to the benefit in heart failure. The problem is that the relevance of these other pathways, these other issues, is that we would need trials that compare aldosterone synthase inhibitors to MRA in patients with heart failure. Packer then laments the fact that these trials are, quote, being strategically avoided, he writes. Being strategically avoided. That's Milton Packer. That's such an interesting comment. I would also add that I feel like, to me, it's exactly what the makers of finerenone did, right? Instead of studying finerenone versus placebo, the heart failure trials should have studied finerenone versus spironolactone. Now, I want to be clear about my thoughts here. The problem here is not industry. Industry does what industry does. They develop products to maximize profits, and that is not one bit nefarious. The problem is that so much of our science, medical science, is funded by industry. And industry will never fund trials that could minimize units sold. Industry-funded science can advance our field, but only when the interests of our field are confluent with profits for the company. Industry-funded science is why we had no trials of conduction system pacing, because conduction system pacing could possibly reduce the number of cardiac resynchronization therapy units sold. Now, fortunately, a number of tireless scientists have now convinced government to fund such a trial. I'm going to cover a pretty weak, awful study later in this podcast that was partially funded by the NIH. Obviously, NIH funding is now in the news, but it's important because we need government. We need NIH to fund important studies in our field that industry will not fund. Such a comparison of aldosterone inhibitor drugs is a great example. But if NIH is burning money and time on low-quality studies, there's going to be less bandwidth and money for important outcomes trials. Packer concludes his editorial by writing, quote, importantly, the need for alternative anti-aldosterone agents has been substantially dampened by the fact that both neprilysin and sodium glucose cotransporter 2 inhibitors mitigate the risk of hyperkalemia in patients with heart failure receiving MRAs. I agree with all of these comments, and I feel like it's sad that MRAs are underused and underthought of. The RALS is an impressive trial, and it appears that potassium binders are neither necessary nor beneficial when it comes to outcomes and the use of MRAs in heart failure. Okay, third topic today is butter versus plant-based oils and mortality. JAMA Internal Medicine has published another one of these nutritional observational studies comparing butter and plant-based oil with mortality as an endpoint. It's led by a group at Harvard Medical School. Now, obviously, seed oils and their danger are also a hot topic in the news. In fact, the altmetric score of this study is already over 2,000, and it's only been out this week. Now, the pattern of this study is common. They used 3 large cohort studies. The primary exposures were self-reports of butter or plant-based oils, which could include safflower, soybean, corn, canola, and mysteriously, they also include olive oil. The main outcome measure is total mortality. Secondary is mortality due to cancer and CVD. Follow-up, 33 years. There were 221,000 adults. Participants were categorized into quartiles based on their butter or plant-based oil intake. And the results, after adjusting for potential confounders, the highest butter intake was associated with a 15% higher risk of total mortality compared to the lowest intake, and that hazard ratio of 1.15 was statistically significant. In contrast, the highest intake of total plant-based oils compared to the lowest intake of oils was associated with a 16% lower total mortality, has a ratio of 0.84, and it was statistically significant. And every 10-gram increment in plant-based oils intake was associated with an 11% lower risk of cancer mortality and a 6% lower risk of CVD mortality, whereas a higher intake of butter was associated with higher cancer mortality, 1.12, and it was statistically significant. The authors concluded higher intake of butter was associated with increased mortality, while higher plant-based oil intake was associated with lower mortality. And get this, the causal verbs. Substituting butter with plant-based oils may confer substantial benefits for preventing premature death. Funding support at the end of the study from numerous grants from the NIH. So my comments. The editorialist who wrote for this study said the study had several strengths, like the large sample size, the long follow-up, and the repeated assessment of diet and adjustment for confounders, and I disagree with all of these comments. As for sample size, this is a hugely important lesson. Perhaps this is the most important lesson you take from today's podcast, and that is that sample size in these observational studies may have no bearing on mitigating bias. Now, when there is a systemic bias, such as butter eaters are different from olive oil eaters, no number of patients can fix such a systemic bias. Large numbers of patients in studies fixed the problem I just mentioned in the REALIZE-K trial, where 11 versus 3 patients had heart failure events, but even 1 million patients does not fix a confounding selection bias like that is in these observational nutritional studies. I would also disagree that adjustments has any chance of sorting out baseline characteristics because, as I've said a gazillion times, you only can adjust for what's on the spreadsheet, and there are many other factors that are not on the spreadsheet. Another problem that this study has, the authors make choices in their analytic method. All authors make choices in their analytic method. But as I have reported before with the work of Dara Zaretker from McMaster's University, who showed with a meat consumption and mortality study that there are literally a quadrillion different ways to analyze a data sheet, and some of these ways lead to positive results, some negative, and most show that there's no effect. Baseline characteristic issues and analytic flexibility are not the only issues with this study. You also have recall bias of the food consumption and the fact that olive oil is mixed in with other seed oils, and clearly olive oil is different than these other seed oils. Plus, there is the matter of implausibility. Come on. It belies any sense of biology to posit that one food component could have this large an effect on mortality. It's not possible. Finally, I want to share a somewhat funny but very enlightening nutritional study published in 2013 by 2 authors, John Schoenfeld and John Ioannidis. The title of this, and I'll link to it, it's a very interesting paper, is Everything We Eat Associated with Cancer, a Systematic Cookbook Review. I'll link to the study. It's in the American Journal of Clinical Nutrition. And in this, the researchers selected 50 random ingredients from a cookbook, and then they searched the scientific literature for studies about these ingredients' relationship with cancer. And they found that 80% of the ingredients had been studied for cancer risk, with 36 of these ingredients having at least one study claiming either an increased or decreased cancer risk. And here's the key findings. Of the hundreds of single studies in this systematic review, 72% concluded that foods were associated with cancer risk. But get this, 39% increased risk, 33% decreased risks. Most of these claims were based on weak statistical evidence, and that single studies often reported implausibly large effect sizes, i.e. the one I just told you about in JAMA Internal Medicine. Meta-analyses presented more conservative results, with only 26% reporting an increased or decreased risk. And the exposure contrasts used across studies were highly variable and inconsistent, which makes any comparisons difficult. So, Schoenfeld and Ioannidis argue that nutritional epidemiology may suffer from several biases, like publication bias, which favors positive results, selective reporting, of analysis that yield significant findings, flexibility in how analyses are conducted and reported, and of course, overinterpretation of weak statistical evidence. My point here is that such studies are totally useless, but you might argue, hey, Mandrola, this study's not just useless, it's worse than useless. It could be even net harmful. Harmful how, you might wonder? Well, perhaps seed oils are worse for you, and this paper might cause increased consumption. But a more likely way this harms society is that papers like this shred trust in medical science. People look at this and they see the flaws and they ask, why would Harvard-based researchers do such a study? Why would a prominent journal like JAMA Internal Medicine publish such flawed work? Where were the peer reviewers? And if we can't rely on journals like JAMA Internal Medicine, who can we rely on? This is so bad, my friends, so bad. However, I want to finish with a positive on vitamin D. No, I didn't misspeak. I've lost track of how many times I've mentioned vitamin D on this cardiology podcast, and every time it's because of a negative vitamin D trial. Well, this is slightly off topic, but JAMA has published an actual positive trial for vitamin D supplementation. I won't say much because the trial tested high-dose vitamin D for the treatment of patients with newly diagnosed multiple sclerosis. My colleague at Medscape, F. Perry Wilson, has a nice recap on his Medscape feature called the Impact Factor. The placebo-controlled trial seemed to show a clinically important and statistically robust effect size for MS. And subgroup analysis suggests that patients with lower vitamin D levels at baseline benefit more, which goes along with the true effect. Benefit also seemed to be strongest in patients with milder disease. I note this trial called the DELAY trial for two reasons. One is that I think it's the first time I've found a very positive vitamin D trial. And secondly, as Dr. F. Perry Wilson notes, perhaps some of the replacement trials for vitamin D that have been negative are negative because of patient selection or not enough dose. This trial used very high doses very early in the disease course. So that's it for this week in cardiology. As always, I'm grateful that you listened. And remember, if you like this podcast, please take the time, give us a review. It helps others find us. If you disagree with something I say, if I've made a mistake, let me know. I'll correct it, and I learn from these comments. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.